Chapter 2, Summary Points. Hematopoiesis is defined as the production, development, and maturation of all blood cells. Erythropoiesis in the fetus occurs in the yolk sac, spleen, and liver. Erythropoiesis in the adult occurs primarily in the bone marrow. Hematopoiesis within the bone marrow is termed intermedullary hematopoiesis. Outside the bone marrow, it's termed extramedullary hematopoiesis. The bone marrow is one of the largest non-solid organs of the body. The M to E ratio, 3:1 to 4:1, reflects the amount of myeloid elements in the bone marrow compared with the erythroid elements in the bone marrow. Multipotential stem cells can differentiate into non-lymphoid or lymphoid precursor committed cells. EPO is a hormone produced by the kidneys that regulates erythroid production. Bone marrow aspirate and biopsy are invasive procedures usually performed at the location of the iliac crest in adults. The CBC consists of 9 parameters: white blood cell, red blood cell, hemoglobin, hematocrit, MCV, MCH, MCHC, RDW, and platelet count. The MCV is one of the most stable CBC parameters over time. Increases in MCV can occur as a result of transfusion, reticulocytosis, hyperglycemia, and methotrexate. The RDW may be an early indicator of an anemia. Critical values are values that are outside the reference range and that need to be immediately reported and acted on. The reticulocyte count is most effective means of assessing red blood cell regeneration in response to anemic stress. Red blood cell production is effective when the bone marrow responds to anemic stress by producing an increased number of reticulocytes and nucleated red blood cells. Ineffective red blood cell production is described as death of red blood cell precursors in the bone marrow before they can be delivered to the peripheral circulation. Morphologic classification of anemias is determined by the red blood cell indices. Microcytic hypochromic anemias are characterized by MCV of less than 80 and MCHC of less than 32%. Macrocytic normochromic anemias are characterized by MCV of greater than 100. Normochromic normocytic anemias are characterized by MCHC of 32 to 36% and MCV of 80 to 100. Normal red blood cells are disc-shaped, flexible sacs filled with hemoglobin and having a size of 6 to 8 micrometers. Chapter 3, Summary Points. Red blood cell production is controlled by EPO, a hormone released from the kidney. The main site of adult erythropoiesis is the bone marrow within the sternum and iliac crest. Each pronormoblast produces 16 mature red blood cells. As they mature, red blood cells decrease in size, become less basophilic in their cytoplasm, develop the orange tinge of hemoglobin, and lose their nucleus. The most common nucleated red blood cell seen in the peripheral smear is an orthochromic normoblast. The red blood cell membrane is a trilaminar structure containing glycolipids, glycoproteins, cholesterol, and proteins that anchor the cell and provide deformability such as spectrin and ankyrin. Integral proteins start from the cytoskeleton and expand through the entire red blood cell membrane. Peripheral proteins are confined to the red blood cell cytoskeleton. Sodium and potassium migrate from the plasma across the red blood cell membranes in an organized fashion controlled by cationic pumps. Deformability and elasticity are crucial properties of the red blood cell membrane, which must be able to extend its surface area up to 117% to accommodate its passage through arterioles and capillary space. The Emden-Meyerhof pathway provides 90% of cellular ATP necessary for anaerobic red blood cell metabolism. Microcytes and macrocytes represent size changes in the red blood cells determined by abnormal pathologies. Microcytes are seen in iron deficiency anemia, in thalassemic conditions, in iron-loading processes, and with the anemia of inflammation in some individuals. Macrocytes are associated with megaloblastic processes, liver disease, high reticulocyte counts, and chemotherapy. The observation of polychromasia on a peripheral blood smear indicates accelerated erythropoiesis. Hypochromia is a color variation in the red blood cell determined by lack of hemoglobin synthesis. Sickle cells are observed when hemoglobin S is part of the hemoglobin component. There are two types of sickle cells, irreversible and reversible. Spherocytes are seen in hereditary spherocytosis, in autoimmune hemolytic anemias, or as part of red blood cell senescence. Target cells are seen in any condition affecting hemoglobin function and in liver disease or other processes where cholesterol is loaded in the circulation. Fragmented cells occur as a result of membrane loss and may be seen in heart valve disease, in burns, or in conditions where there's a predisposition of thrombi. Ovalocytes can be seen in thalassemic processes and in megaloblastic anemias in which macroovalocytes are seen. Elliptocytes are seen in iron deficiency anemia, hereditary elliptocytosis, and idiopathic myelofibrosis. Acanthocytes are red blood cells that are smaller and possess uneven, thorny projections. Howell-Jolly bodies are DNA in origin and seen in conditions of accelerated erythropoiesis. Basophilic stippling is RNA in origin and is seen in lead poisoning and accelerated erythropoiesis. Heinz bodies are formed from denatured hemoglobin, usually from patients with G6PD deficiency. Siderotic granules, or Pappenheimer bodies, are iron in origin and seen in iron-loading processes or in patients who are hypertransfused. Chapter 4 Summary Points. Hemoglobin has two main components, heme and globin. Heme consists of iron and protoporphyrin ring. Globin consists of amino acid chains of specific lengths, and specific amino acids, such as alpha and beta chains, are the two most significant amino acid chains. Alpha chains have 141 amino acids, and beta chains have 146 amino acids. Hemoglobin F is fetal hemoglobin. The adult hemoglobins are hemoglobin A, hemoglobin A2, and hemoglobin F. Oxygen delivery is the primary purpose of the hemoglobin molecule. 2,3-DPG is intimately related to the oxygen affinity of hemoglobin because it regulates the loading and unloading of oxygen. The OD curve schematically represents the saturation of hemoglobin with the oxygen and release of oxygen from the hemoglobin molecule under normal and abnormal physiologic conditions. Hemolysis is the destruction of the red blood cell before the end of its 120-day life cycle. Hemolysis may be classified as intravascular or extravascular, which relates to the site of hemolysis. Intravascular hemolysis occurs inside the blood vessels. Extravascular hemolysis occurs outside the blood vessels, primarily in the reticuloendothelial system. Hemolytic anemias may be classified by intrinsic defects of the red blood cell or extrinsic defects that affect the red blood cell. Chapter 5 Summary Points. An anemia classified as microcytic hypochromic means there is decreased MCV and decreased MCHC. The most common microcytic anemias are IDA, sideroblastic anemias, HH, and anemia of chronic disease. Iron is ingested, absorbed from the duodenum and jejunum, and then moved to the bone marrow by transferrin, the transport protein. Individuals with IDA experience symptoms of anemia and perhaps cheilitis, koilonchia, or pica. Individuals with iron deficiency have decreased serum iron and serum ferritin and increased TIBC. Anemia of chronic disease or anemia of inflammation is one of the most common anemias in the hospital population. HH is an inherited iron-loading anemia. Multiple organs are affected in HH because individuals with HH have been iron-loading for decades. Serum iron and serum ferritin are high in HH. Therapeutic phlebotomy is the therapy of choice for HH. The thalassemia syndromes are globin chain synthetic defects. There are 4 clinical conditions of alpha thalassemia, each caused by gene deletions. Beta thalassemia major is the most severe of the beta thalassemic conditions. Individuals with beta thalassemia major have severe anemia, splenomegaly, and thalassemic facies. The majority hemoglobin in beta thalassemia major is hemoglobin F. Beta thalassemia minor is similar to IDA, with the exception of an elevated red blood cell and an elevated hemoglobin A2. Chapter 6 Summary Points. Macrocytic anemias have MCV of greater than 100 and normal MCHC. Megaloblastic anemias are macrocytic anemias in which vitamin B12 or folic acid, or both, are deficient. Not all macrocytic anemias are megaloblastic. Vitamin B12 and folic acid deficiencies lead to impaired DNA synthesis. The bone marrow in megaloblastic anemias is hypercellular, with the red blood cell precursors showing distinct chromatin and cytoplasmic changes. Megaloblastic anemias show ineffective erythropoiesis in the bone marrow, premature destruction of red blood cell precursors before delivery into the circulation. The peripheral smear in megaloblastic anemia shows macrocytes, oval macrocytes, and hypersegmented neutrophils. Pancytopenia and reticulocytopenia are prominent features of the megaloblastic processes. Patients with megaloblastic anemia may exhibit symptoms of anemia and neurological symptoms, gastrointestinal symptoms, and psychological symptoms. Many elderly individuals are not diagnosed with vitamin B12 deficiency because their symptoms are assumed to be related to other illnesses. Intrinsic factor, which is secreted by the parietal cells of the stomach, is necessary for vitamin B12 absorption. Intrinsic factor deficiency can lead to a pernicious anemia, a subset of megaloblastic anemia. Intrinsic factor deficiency may develop because intrinsic factor is not being secreted or because it's being blocked or neutralized. Of individuals experiencing pernicious anemia, 90% have parietal cell antibodies. Folic acid deficiency is the most common vitamin deficiency in the United States. Serum vitamin B12, folic acid, and red blood cell folate can be determined by radioimmunoassay. Individuals with vitamin B12 deficiency require lifelong therapy. Folic acid deficiency requires short-term therapy. Serum methylmalonic acid and homocysteine are sensitive indicator tests of mild vitamin B12 deficiency. There are causes of a macroanemia other than megaloblastic processes. Macrocytes may be seen in reticulocytosis, alcoholism, or liver disease. Chapter 7 Summary Points. The spleen plays a vital role in filtration of red blood cell imperfection. Hereditary spherocytosis is an autosomal dominant disorder of several membrane proteins, the key protein being spectrin. Spherocytes are less deformable and are more osmotically fragile. Patients with hereditary spherocytosis have splenomegaly, jaundice, and an increased tendency for gallstone disease. The osmotic fragility test is a labor-intensive test that measures red blood cell hemolytic response in different hypotonic salt solutions. Hereditary elliptocytosis, or HE, is a membrane disorder of spectrin showing decreased thermal stability. There are several clinical variants of HE, including common HE, Southeast Asian ovalocytosis, and spherocytic HE. Hereditary pyropoikilocytosis is a recessive membrane disorder with a bizarre red cell morphology that shows hemoglobin budding. Hereditary stomatocytosis is a membrane disorder in which red blood cells have an intrinsic defect to sodium and potassium permeability. Glucose 6-phosphate dehydrogenase, or G6PD, deficiency is the most common enzyme deficiency in the world. G6PD is an X-linked recessive disorder with more than 400 variants. Drug-induced or infection-induced hemolysis is G6PD is intravascular, brisk, and self-limiting. Most individuals with G6PD deficiency are unaware of their hematologic condition until they are challenged by a drug that produces oxidant stress. Pyruvate kinase deficiency is an enzyme deficiency of the Embden-Meyerhof pathway. Aplastic anemia is a hypoproliferative disorder in which there is cellular depletion and reduced production of blood cells. Fanconi's anemia and Diamond-Blackfan anemia are rare hypoproliferative disorders with congenital malformations. Paroxysmal nocturnal hemoglobinuria is a hemolytic anemia that is caused when 9 red blood cell surface proteins are absent and red blood cells become increasingly sensitive to complement lysis. Cold agglutinin syndrome is a disease affecting elderly individuals that is caused by an IgM autoantibody of wide thermal range. Paroxysmal cold hemoglobinuria is an extremely rare hemolytic disorder caused by anti-P of a wide thermal range. Congenital dyserythropoietic anemias are extremely rare and classically show scattered nuclear chromatin patterns in all red blood cell precursors. Red blood cells may become hemolyzed as a result of external forces, such as parasitic invasion, scattered and unexpected fibrin deposition throughout the circulation, exposure of red blood cells to intense temperature, and excessive lead deposition, to name a few. Chapter 8 Summary Points. Most hemoglobinopathies are the result of single amino acid substitution in the beta chain. In sickle cell disorders, valine is substituted for glutamic acid in the 6th position of the beta chain. In hemoglobin C disorders, lysine is substituted for glutamic acid in the 6th position of the beta chain. The presence of hemoglobin S affords some protection against malarial infection of red blood cells. Cells containing hemoglobin S as the majority hemoglobin are insoluble in areas of the body with low oxygen tension. Sickle cells clog small vessels during sickling crisis, causing extensive organ damage and pain. Homozygous inheritance of hemoglobin S produces sickle cell anemia or hemoglobin SS. Heterozygous inheritance produces sickle cell trait or hemoglobin AS. Hypoxia, acidosis, dehydration, cold, and fever predispose a patient to sickling episodes. The only Food and Drug Administration approved drug for adults with sickle cell disease is hydroxyurea. Autosplenectomy is a consequence of repeated infarctions to the spleen in young children with sickle cell disease. Stroke and acute chest syndrome are serious complications in patients with sickle cell disease. During sickle crisis episodes, patients show nucleated red blood cells, sickle cells, target cells, and polychromasia. White blood cells may need to be corrected owing to the presence of nucleated red blood cells during sickling episodes. Individuals with sickle cell trait are asymptomatic with rare abnormalities in the peripheral smear. Newborn screening for hemoglobinopathies is available in the United States through state health laboratories. Dithionite solubility is the usual screening procedure to determine if hemoglobin S is present. Acid or alkaline electrophoresis and IEF provide better methods to isolate hemoglobin bands. Hemoglobin C disease occurs when hemoglobin C is inherited homozygously. Hemoglobin C trait occurs when hemoglobin C is inherited heterozygously. Hemoglobin C disease may produce hemoglobin C crystals on right stain. Hemoglobin SC is the result of inheriting two abnormal hemoglobins, hemoglobin S and hemoglobin C. Hemoglobin SC may produce abnormal crystal formation resembling the Washington Monument or fingers in a glove. Hemoglobin S, beta thalassemia, may produce conditions as severe as sickle cell disease. Hemoglobin E is the second most prevalent hemoglobin variant and is seen with great frequency in Southeast Asia. Hemoglobin D Punjab and hemoglobin G phyla migrate with hemoglobin S on alkaline electrophoresis. Chapter 9, Leukopoiesis, White Blood Cell Differential, and Lymphocyte Function Summary Points. The M to E ratio in the bone marrow is 3 to 4 to 1. The segmented neutrophils are held in the marginating pool for 5 to 7 days before release to circulation. The maturation sequence for neutrophils from least mature to most mature is myeloblast, promyelocyte, myelocyte, metamyelocyte, band, and then segmented neutrophil. Cell identification is based on cell size, N to C ratio, presence or absence of granules, presence or absence of nuclei, chromatin pattern, and texture of cytoplasm. The marginating pool designates white blood cells located along the vessel endothelium. The circulating pool designates white blood cells present in the bloodstream. Lymphocytes originate not only from the bone marrow, but also from the thymus gland and the lymphatic system. The bone marrow and the thymus are the primary lymphoid organs. Spleen, lymph nodes, Peyer's patches, and tonsils are the secondary lymphoid organs. The lymphatic system plays an important role in blood filtration, fluid balance, antibody generation, and lymphopoiesis. T cells represent 60% to 80% of the total lymphocyte count. B cells represent 10 to 20% of the total lymphocyte count. T helper and T cytotoxic suppressor cells are essential in cell-mediated immunity. B cells are responsible for humoral immunity, which is antibody production by plasma cells. Absolute counts are derived from total white blood cells multiplied by the relative percentage of a particular white blood cell in the differential. Chapter 10, Abnormalities of White Blood Cells, Quantitative, Qualitative, and the Lipid Storage Diseases. Summary points. Infections and inflammation increase the number of neutrophils in the peripheral smear. Leukocytosis means an increase in white blood cells. Eosinophils are increased in skin diseases, parasitic infections, allergic response, and transplant rejection. A left shift signifies that younger white blood cells appear in the peripheral smear, such as occasional metamyelocytes, many bands, and segmented neutrophils. Leukemoid reaction is an exaggerated response to infection or inflammation. In leukoerythroblastosis, immature white blood cells, immature red blood cells or nucleated red blood cells, and platelet morphologic abnormalities are seen. Phagocytosis is a process by which bacteria and other infectious agents are recognized and ingested by neutrophils and monocytes. Toxic changes in white blood cells are observed as toxic granulation, toxic vacuolization, and Dolly bodies. Hereditary white blood cell disorders include May-Hegland anomaly, Pelger-Hewitt anomaly, Alders anomaly, and Shide-Higashi syndrome. Pelger-Hewitt anomaly is a hyposegmentation disorder in which the lobes of the segmented neutrophils are peanut-shaped or bilobed. Alders anomaly is a disorder in which lipid deposition produces coarse, dark granules in the cytoplasm of granulocytes and occasionally agranulocytes. A hypersegmented nucleus, 5 lobes or more, is seen in megaloblastic disorders. Shide-Higashi syndrome is a rare autosomal disorder of neutrophilic granules. Human ehrlichiosis and human granulocytic anaplasmosis represent a group of tick-borne diseases caused by the rickettsia-like bacteria Ehrlichia chafensis or Anaplasma phagocytophilum. Inclusions known as morulae may be observed in the granulocytes and monocytes of the bone marrow. Reactive lymphocytes are lymphocytes transformed by viral infections or other disorders. Reactive lymphocytes are characterized by abundant basophilic cytoplasm, lower N-to-C ratio, and clumped chromatin material. Marginal erythrocyte molding is seen. Infectious mononucleosis is caused by Epstein-Barr virus. Patients have low-grade fever, sore throat, swollen glands, anorexia, and headache. Individuals with AIDS show pancytopenia and a reversal in CD4 and CD8 lymphocyte ratios. Bacteria may appear intracellularly in neutrophils or may appear within the peripheral smear. Lipid storage diseases are a group of inherited disorders in which a key metabolic enzyme is missing or inactive. Gaucher's disease and Niemann-Pick disease are lipid storage disorders that show large histiocytic-like cells in the bone marrow. Chapter 11. Acute Leukemias. Summary points. Leukemia is caused by the mutation of bone marrow pluripotent stem cells. Individuals with acute leukemia present with variable white blood cells, anemia, and platelet counts. Signs of leukemia include fever, fatigue, bruising, petechiae, and bone or joint pain. When blast cells accumulate in the bone marrow and peripheral smear, leukemia is classified as acute. The bone marrow is always hypercellular in acute leukemia. Our rods are composed of fused primary granules and may be present in myeloblasts, monoblasts, and promyelocytes. Hepatosplenomegaly or lymphadenopathy is more prominent in chronic leukemias than acute leukemias. According to WHO, the peripheral smear must contain greater than or equal to 20% myeloblasts for a diagnosis of acute leukemia. Skin infiltration is characteristic of monocytic leukemias. Extramedullary hematopoiesis is common in monocytic or myelomonocytic leukemias. Headache, blindness, and other neurologic complications are indicative of blast cells crossing the blood-brain barrier. There are many different subtypes of both AML and ALL. Tests to identify and define the subtype of acute leukemia include CBC, bone marrow aspirate, and biopsy, cytochemistry, immunophenotyping, cytogenetics, and molecular genetics. Cytochemical staining can assist in the diagnosis of acute leukemias based on staining patterns, particularly AMLs. Immunophenotyping can help to classify the clone of leukemic cells by using monoclonal antibodies in flow cytometry or immunohistochemistry procedures. Cytogenetic abnormalities, such as translocations and deletions, are an important prognostic feature of many acute leukemias. Treatment with cytotoxic chemotherapy or radiation therapy is associated with the development of acute leukemia and myelodysplastic syndrome. AML is the most common type of acute leukemia in adults. APL is often associated with DIC. ALL is the leukemia of childhood. ALLs account for approximately 75% of all leukemias diagnosed in children younger than 13 years. The leukemic cells in ALL persist in both intramedullary and extramedullary sites. Children with DS have an increased risk of leukemia. Lymphoblasts frequently cross the blood-brain barrier, causing neurologic involvement. Children with ALL have an overall complete remission rate of almost 95%. Certain factors affect prognosis and treatment options, such as the age of the patient, subtype of the leukemia, whether or not the patient has been previously treated with chemotherapy, whether the leukemia has spread to the central nervous system, and other factors related to patient history, cytogenetic abnormalities, and molecular abnormalities. It is very important that acute leukemias be treated promptly. Chapter 12, Myeloproliferative Neoplasms, Summary Points. MPNs are caused by abnormal stem cells that lead to unchecked autonomous proliferation of one or more cell lines. The most common MPNs are CML, PV, PMF, and ET. The bone marrow in MPNs may show hyperplasia or elements of fibrosis. Most MPNs are seen in older adults and show a normochromic, normocytic anemic process. Individuals with CML have extremely high white blood cell count, moderate anemia, and the entire spectrum of white blood cells in the peripheral smear. PH plus chromosome is present in 90% of patients with CML. This is a cytogenetic abnormality in which a small part of chromosome 9 is translocated to the broken arm of chromosome 22. A hybrid gene, BCR-ABL1+, is also manifested with PH chromosome. This gene prevents natural cell death or apoptosis. In the accelerated phase of CML, a higher blast count may be present and eventually results in blast crisis, with all blasts in the bone marrow. PV is a clonal disorder of red blood cells in which the patient shows a pancytosis, high red blood cells, high white blood cells, and high platelet count. The JAK2V617F mutation has been shown in large numbers of patients with PV and in fewer patients with ET and PMF. Patients with PV have symptoms related to hyperviscosity, including hypertension and vascular abnormalities. Patients with PV must be distinguished from patients with secondary or relative erythrocytosis. The major causes of death in patients with PV are hemorrhage and thrombosis. PMF is characterized by myelofibrosis, extramedullary hematopoiesis, and the leukoerythroblastic blood smear. In patients with PMF, the accelerating fibrosis may contribute to leukopenia and thrombocytopenia. In 50% of patients with PMF, bone marrow aspirates are impossible because of increased fibrosis or the dry tap. PMF has the worst prognosis of all the myeloproliferative disorders. ET is a clonal proliferation of megakaryocytes in the bone marrow. The peripheral platelet count of patients with ET is extremely elevated, sometimes up to 1,000 times 10 to the 9th per liter. The increased platelet count in ET can cause hemorrhagic and thrombotic episodes, including gastrointestinal bleeding, epistaxis, and transient ischemic attacks. Diagnosis of ET involves ruling out any causes of reactive thrombocytosis other than the clonal proliferation of megakaryocytes. Mastocytosis is a separate category defining conditions of mast cells, which are associated with allergies, inflammation, and sometimes leukemic manifestations. Chapter 13, Lymphoproliferative Disorders and Related Plasma Cell Disorders. Summary points. In lymphoproliferative disorders, there's a clonal malignant proliferation of either B lymphocytes or T lymphocytes. CLL is a clonal proliferation of B lymphocytes that is seen in older patients and often discovered by accident. CLL shows an accumulation of mature lymphocytes in the bone marrow and eventually the lymph nodes, spleen, and peripheral blood. White blood cells in CLL can be extremely elevated, and M/E ratio is 10 to 1 or 20 to 1. Immune function is compromised in CLL, and 10% to 30% of patients may experience autoimmune hemolytic anemia. HCL is a rare B-cell malignancy in which the cells have a lymphoid appearance with hair-like projections in the cytoplasm. Pancytopenia, splenomegaly, and dry tap are the key features of HCL. Sézary syndrome is the blood equivalent of cutaneous T-cell lymphoma that shows a convoluted cerebriform ovoid nucleus. MM is a disorder of plasma cells that leads to a monoclonal gammopathy, bone involvement, and pancytopenia. Most abnormal proteins are an accumulation of IgG, which may lead to plasma hyperviscosity and rouleau in the peripheral smear. Serum calcium is elevated in patients with MM because of bone loss and increased distribution of calcium in the peripheral circulation. Bence-Jones protein may be seen in individuals with MM. Plasma cell leukemia is a complication of MM in which mature plasma cells are seen in increasing numbers in the peripheral circulation. Waldenstrom's macroglobulinemia is a rare disorder of plasma cells in which IgM is overproduced. Many symptoms of Waldenstrom's macroglobulinemia are related to hyperviscosity of the plasma, which accounts for coagulation abnormalities, rouleau formation, and bleeding or thrombotic complications. Plasmapheresis, the therapeutic removal of plasma, may be used as a treatment to decrease the amount of abnormal IgM protein. Chapter 14, the Myelodysplastic Syndromes, Summary Points. MDSs are a group of clonal disorders characterized by refractory anemias and cytopenias of one or more cell lines. The bone marrow and peripheral smear show dysplastic changes in white blood cells, red blood cells, and platelets over time. Dyserythropoietic changes include multinucleated red blood cell precursors, bizarre nuclear changes, nuclear bridging, macrocytes, and dimorphism. Dysgranulopoietic changes include abnormal granulation of mature cells, hypersegmentation, hyposegmentation, or complete lack of granulation. Dysthrombopoietic changes include micromegakaryocytes, abnormal granulation, no granulation, and giant platelets. The blast count in MDSs is less than 20% in the bone marrow. Patients with MDSs may present with weakness, infections, and easy bruising. According to the World Health Organization, there are 9 MDS classifications. Chapter 20, Hematology Automation and Flow Cell Cytometry, Summary Points. Electrical impedance occurs as the cells pass through the aperture, causing a change in voltage and generating a pulse. Column conductivity and scatter technology differentiates white blood cell characteristics. Flow cytometry uses a laser light source to measure the physical or antigenic characteristics of cells as they pass through the beam of laser lights. Basic automated hematology analyzers provide an electronically measured CBC. Automated analyzers usually include a 5-part automated differential and often an enumeration of the nucleated red blood cells. CLSI provides guidelines for instrument calibration, calibration verification, instrument validation, and quality control. Quality control for hematology analyzers involves stabilized control material run every 8 hours using 3 levels of control. Prior to automated methods in coagulation, semi-automated clot timers and optical and mechanical methods were employed. Presently, automated methods in coagulation include nephelometry and chromogenic and immunologic procedures. TEG is a point-of-care product that measures the strength of a clot using torsion wire. As an automated operator, it is essential to be aware of your institution's reference ranges and to be able to interpret scatter plots and histograms. Flagging criteria are imposed on a sample by the automated instrument when the sample fails to meet reference standards. Delta checks and reflex testing are part of the corrective action criteria that professionals must employ. Critical results are results that exceed or are markedly decreased from the reference ranges. Flow cytometry measures physical and chemical properties of cells and the phenotype of cells, and defines the maturation of cell stages. Flow cytometry consists of many systems, including transport, optics, light scatter, electronics, and data storage. Most instruments for flow cytometry use 4 different monoclonal antibody markers, each labeled with a different fluorochrome. Data from flow cytometry are displayed by a single or 2-parameter histogram or by a contour plot.